So yes, I'm going to talk to you about primary care networks. So we are obviously in the final year, so I thought I'd have just a bit of a review about where we have come from, where we're at the moment, and what the future might look like for primary care networks. So obviously they started as part of the 2018-19 contract. As usual with the NHS, the contract changes were announced February-March time, and you were all expected to form part of a primary care network, and you were given about 3 months to sort yourself out for that. And as always with general practice, you rose absolutely to the challenges for that. And so the first PCN network started in July 2019. At that time, the maximum funding for year one for a 30,000 patient practice, and when I'm talking about patient numbers, I'm actually ignoring the impact of patient waiting. So just say a standard 30,000 patient PCN. That maximum funding in that year was about £181,000 for a 1 year. And the ARS roles were just covering the basics, so clinical pharmacists and social prescribers. So many practices already had clinical pharmacists in place, so they've moved them out into the networks. If we now fast forward to this end year that we've got for our primary care networks, the maximum 5-year funding for a 30,000 patient network is now over £1 million. So it's a massive increase in the funding that you've got. And that excludes the impact of care home funding as well. So I've literally just taken the funding per patient that you've got and multiplied it by the patient numbers that you've got. And you will all know that the primary care networks have become far more complex, both in their size, the amount of staff that you've got, and also the administration that actually goes with it as well. So there are many primary care networks where it started off with the finances being looked after by one of the practice managers. And as we have evolved through the enhanced service, many primary care networks have then increased their staffing and quite often will have a PCN manager in place, because a lot of people are trying to do the role on a part-time basis, and actually it has grown significantly, and yeah, you just need the additional staff that goes in there. The ARS roles are now covering 18 different roles. So we've gone from the first year where we had 2 roles, and now we are covering 18 different roles. And that is a huge array, but will include things like the nursing associates, and now we've got digital and transformation leads that we've got in there. We've also got some new roles for 2023-24, and I'll talk about those a little bit later, which is giving the idea of the apprentice physician associate and the advanced clinical nurse practitioners. So this is all about bringing in additional staff to be able to help with the service specifications that have been brought in over the last couple of years. And it's interesting actually that I'll come on later about how practices have done with the ARS roles, but generally you are looking to be hitting the targets in terms of what the government had wanted for the whole-time equivalent to the ARS roles. So there are definitely people out there to be taking those posts that we've got. So if we have a look at what we've got for the funding for 2023-24, we have a number of areas. So some things have changed slightly, but others are remaining the same. So our core funding has remained at £1.50 per registered patient from the time that the primary care networks were first established. We've then got some clinical director funding that's paid per registered patient again, so 0.729 per registered patient. That is slightly less than it was for 2022-23. It's a fraction of a pence, but it is still a little bit less. Then we've got the enhanced access. So that was effectively formed from the funding for the extended hours and the improved access, and that's paid on a per weighted patient basis. that income that you're receiving is fractionally more than the combined income that you had for the improved access and the extended hours. Those two added together would have been £7.44 per weighted patient. Then we have the care home premium, so that's remaining at £120 per care home bed, and that's based on the information held by CQC. We've then got the PCN leadership and management money, so that's 0.684 per weighted patient. Again, that funding is down fractionally compared to the previous year. And then we've got the areas where we have the largest level of additional income for 2023-24. So we have the capacity and access support, which is paid at £2.76 per weighted patient. That funding started from October 2022, and effectively, as I'll talk about in a minute, that is money that has been reallocated out from the investment and impact monies for you. And as Jo mentioned, access really is one of those key areas for 2023-24. But the capacity and access funding, which started in October 22, was on an annual basis last year £1.20. So you can see you've got quite a significant increase in that funding for 2023-24. And then we've got the R's roles funding. Now, this is the maximum that you can be paid on a per weighted patient basis. Obviously, there are within each individual banding, there is a maximum reimbursement level. If the PCN is paying those individuals more, then that is effectively just coming out of the surplus from the primary care network. But the R's funding for 2022-23 was £16.696 per weighted patient. So that income has gone up by £5.97 per weighted patient for 2023-24. So as I said, that is quite a significant increase in that funding that you've actually got. So looking at the change that we've got on the investment and impact fund, as I said, as Jo mentioned, improving access is the main focus that we've got of the 23-24 contract changes. And in order to free up the money for access, there have been quite significant changes to the investment and impact fund. In particular, the number of indicators has been reduced quite significantly. So you did have 36, and now it's gone down to 5. So it's covering those key priorities that we have. So there are 2 indicators for flu, then we've got the learning disabilities health checks, early cancer diagnosis, and then the 2-week access that goes with that. And so 70% of the investment and impact money is going to effectively pay to practice on a monthly basis as your capacity and access. So that's where the majority of that extra income is coming from. And then the remaining 30% of the IIF money that has been allocated for improving the patient experience is based on an access improvement plan. So each of the networks will need to submit ideas for improving access to the ICBs. And then at the end of the NHS year, you will be judged on the performance of the network against that access improvement plan. And then if you've managed to hit those targets, then the additional 30% of funding will be available to you. There's quite a significant change that we've got for this year on that one. Then looking at the additional roles reimbursements that we've got. So as at the end of December 2022, the recruitment through the R's roles was effectively equivalent to 25,262 full-time equivalents, which is an absolutely huge number of individuals that have now been recruited into those positions. And the target was 26,000 by March 2024. So absolutely well on target, I think, to hit that, and actually it may potentially exceed those numbers. I know within each individual PCN there are different challenges to recruitment, and space is also a particular issue that we've got, and also actually managing the payroll aspects of all of the extra individuals that you've got. But the idea is that this extra investment in the ARS roles is again related to the additional appointments and the improving access. So we had some additional roles that for further recruitment following from April 2023. So they had introduced things like the advanced clinical nurse practitioner, and that is the same reimbursement as for the advanced practitioners. But also there has been an increase in the caps on the advanced practitioners that can be used. So if your PCN, your list size is less than 100,000 patients, which probably the majority of you, then you can now have 3 advanced practitioners rather than 2. And then where the list size is over 100,000, the cap has actually been doubled. So you can have 6 advanced practitioners rather than 3. So quite an increase that you've got there. Also, then we've got the new apprentice physician associates reimbursable role. We've had some caps that have been removed for the mental health practitioners, and another change is that the clinical pharmacist can be supervised by the advanced clinical pharmacist. So, we really are expanding out on who can actually be used within those networks. We also had some changes from September 2022, again reflecting the introduction for more of the access targets, was so for trying to have a GP assistant role. So that was a new role that was effectively created, and the idea of that was to try and help reduce the administrative burdens for GP teams. And then we've got the digital and transformation lead role. So that's very much looking at the using technologies to be able to improve the patient experience, and basically, again, improving the access that we've got. So, as I said, the core focus for this year is to do with access. We've got additional roles reimbursements that can go with that, and that's where we're at with this current year that we are in. So there will be networks that are taking on additional staff that you've got for this next year, even though we don't quite know what is actually ultimately going to happen with the enhanced service ultimately. Now, there have been some questions over the past with regards to structures for primary care networks, and particularly issues with regards to the pension scheme. And these changes that we've got here, I think, are also indicative potentially about where the direction of travel may go with regards to the future for primary care networks and what they might look like in the future in terms of their structure and being separate legal entities. So generally, where you have people employed on the ARS roles, if they're employed via a practice, that is absolutely fine for pension scheme purposes. They are employed by a practice that holds a qualifying contract, absolutely no issues that we've got there. If they are employed via a federation or a limited company, and I am aware that there have been some limited companies being set up for the primary care networks, there is not necessarily any automatic access to the NHS pension scheme. Access has been granted either on a directional determination status. And the reason why they don't necessarily have the automatic enrolment is because the federation or the company may not be an employing authority, so there's no automatic pension scheme access. So that directional determination status was actually only time limited up to the 31st of March 2023. So that potentially, so people looking to incorporate were potentially looking at the issue that from March 2023, that pension scheme access would actually be withdrawn. However, there was a consultation that took place in December, and the responses to that was actually published in March 2023. So what that said was that they would grant permanent access to the NHS pension scheme for any organisation that currently had directional determination status or an independent provider status. The prerequisite with that, though, is that there is going to be a standard PCN subcontract that has been published, and the federation or limited company needs to work with the PCN subcontract in order for those staff to be granted the access to the NHS pension scheme. So that's kind of, in my mind, opening up the possibility for the networks to be limited companies going forwards after this enhanced service is actually, the specification is finished, with the guarantee that people will be able to have access to the NHS pension scheme, which I think is a really important aspect of it. So as I said, we're coming to the end of our enhanced service at the end of March 2024, and there's a question about really what's going to happen afterwards. Now, there has been a number of reports and documents published, but one of them was actually the Fuller stock take, which was published in May 2022 and was looking about how we go forward in terms of integrating the primary care. And this was very much looking at where we're at the moment with the primary care networks and how we continue to integrate that within the more community settings and then build on those relationships that you have already made with various third-party organisations to be able to deliver the enhanced services, and actually building on that, and then saying that there should be support for the networks to deliver the ARS roles, particularly after April 2024. It did specifically mention that there needs to be some investment in PCN leadership. So hopefully that will come through. And there's an extent to which we do also have the leadership and the management funding that comes through just generally now for the enhanced service that we've got at the moment. So I still think that, you know, the networks will survive in some kind of format. At the end of the day, an awful lot of funding has been put into the primary care networks and those additional ARS roles. And what has been achieved has been really good in many, many areas. There's been lots of different success stories from that. And to remove any of that funding would be completely destabilising. But, you know, what is going to happen? You know, in your current format, it is quite unclear as to what is actually going to happen. I've said for a while that my personal opinion is the fact that, you know, they would need to be a separate legal entity. ICBs, I think, will be wanting to contract with the networks directly. And particularly North West London ICB published a draft enhanced service contract that would basically look to move a lot of the local enhanced services within the primary care networks, and that they are basically forcing the networks to become a single legal entity. I think probably what's clear is that what will happen is what normally happens with the NHS is that you'll probably find out the contract changes probably about January, February time next year. And again, you will rise to the challenge and organise yourselves into whichever groups that you need to at the moment. But I would definitely anticipate that there'll be a move to commission more services via a PCN type of model, like you had for the vaccine rollout, and that, you know, they will be delivering services directly. And the fact that, you know, permanent access to the NHS pension scheme is open for the two non-traditional models suggests that the NHS is open to potentially the limited companies providing the PCN services. But like I said, it's probably a bit of a wait and see to see what happens with the networks. But like I said, I certainly see them going forward, you know, in a guise that is similar to what you've got at the moment. So that's my bit that I've got then on the primary care networks. I suspect that probably this time next year, we'll be having another further discussion about where we go next and what it will all look like.